I'm very pleased to be here to talk a little bit about a subject that I've spent most of my professional life researching and studying and working on. So I hope that I'll provide you with some useful information and that you'll take home some things from this. And the way I've structured my presentation this morning is to, first of all, just say a few words about lymphoma in general. I know that probably all of you here have some vested interest in lymphoma and know a lot about lymphoma. But I'm going to start off with just a few general points about the different types of lymphomas that we see. And then I'm going to spend most of the presentation talking about what I think are the major advances that have occurred over the last few years and that are continuing to occur and influencing how we manage people with lymphoma. So what is lymphoma? This is a slide which shows that lymphomas arise from a single lymphocyte. Mutation occurs as these lymphomas are developing. Initially, believe it or not, the mutation occurs or the changes occur in the bone marrow where this lymphoid precursor is arising from stem cells. And there's probably some mistakes in some of the programming of these lymphocytes which allow these lymphocytes or cause these lymphocytes to survive and to avoid certain signals that tell them to die. So that you have now a lymphocyte that through its differentiation in the bone marrow has a predisposition to stay alive. And then as this lymphocyte sees antigen and is stimulated to proliferate, because lymphocytes are a part of our immune system and are programmed to see antigens and to respond to antigens and to proliferate in antigens. These cells, because of this mistake that occurred in their early bone marrow life, continue to accumulate. They don't sort of regress after they've seen antigens. They don't decrease in numbers. And then as they further differentiate in lymph nodes, they acquire additional mutations. And depending upon where these mutations occur in the differentiation of these cells in the lymph node, you get different types of lymphomas developing. Follicular lymphoma, diffuse large B-cell lymphoma, sometimes Burkitt's lymphoma, and then as the cells are more mature and differentiating towards plasma cells, if you have mutations occurring there, you can end up with lymphoplasmacytoid or Waldenstrom's types of lymphomas and other types of lymphomas. So the point is, this is a clone that very early on, a single cell, that something happens to it, a mutation occurs that predisposes it to avoid dying, and then these additional events occur which allow it to survive and to proliferate. And an important point is that this clone, as it differentiates, may acquire multiple different mutations. And you may have subclones from this original clone that develop that have different features, maybe have an ability to divide quicker or be resistant to certain types of drugs or whatever. So a lymphoma, even though it arises from a single clone, the cells are actually quite different from each other, but they do arise from a single cell. So there are many different types of lymphomas, as I've sort of alluded to. There are lymphomas that we call indolent lymphomas, a whole group of lymphomas that are indolent. There's the aggressive category of lymphomas. We use the word aggressive. I've always thought that was a bad term to call these lymphomas, but it does give the description that these lymphomas grow a little quicker than the indolent lymphomas. And then we have some of these other types of lymphomas which are even more aggressive. We call them acute leukemia-like type of lymphomas. And lymphomas, for the most part, most of the ones that we see here in North America are B cell, but we do have lymphomas that arise from T cells as well. And these are also clones that have mutations occur as these cells are differentiating. The differentiation process is different for T lymphomas. And it's important for your oncologist and hematologist to know exactly what type of lymphoma you have, because all of these lymphomas are treated somewhat differently and have different natural histories. The most common type of indolent lymphoma is follicular lymphoma, and the reason why it's called follicular lymphoma is that all of you, I think, can see that they're actually, when you look at a slide from a patient's lymph node with follicular lymphoma, there are all these nodules or follicles, and that's why it was called follicular lymphoma. These account for about a quarter of the lymphomas that we see. They're slow growing. We believe that these are not lymphomas that we can cure, but we have many effective therapies that can put these in remission, and we have a number of new drugs that are being developed for these. The diffuse large cell lymphomas, you can again see that these are actually made up of bigger cells. We don't see those follicles. It's actually a diffuse infiltrate of these cells. These also account for about 25 or 30% of the different types of lymphomas that we see. These are the two most common lymphomas that we see in the clinic. These are fast growing. We try to treat these as quickly as we can. Our objective is to obtain a complete response, and we do have a number of new drugs, and I'll be talking about them that are in development for these lymphomas as well. And then the third major type of lymphoma that we commonly see are Hodgkin's lymphomas. This is not as common as the other two categories of lymphomas. These occur predominantly in younger patients. This is a different type of disease, whereas I showed you before there seemed to be monotonous either nodules or follicles in the lymph node biopsy or a diffuse growth pattern. You can see that the cells in Hodgkin's disease are very different. There are large cells, small cells. It's really a collection of a number of different cells that are responding to changes in sort of like the cytokine environment that's created by the so-called Reed-Sternberg cell. And this is a disease that we have very effective treatments for. The cure rate is 85 or 90%. And the focus now in research here is to try to take a step back on the treatment to basically make the treatment a little easier and to avoid some of the long-term potential complications that have been noted to occur with some of the drugs we use for Hodgkin's disease. This has been a very gratifying field to be involved in and to be active in. There have been very significant advances in the management and outcome for patients with lymphoma over the last number of years, probably more so in this disease than any other cancer. In the lymphoma, when I first started practice a number of years ago, we talked about prognosis. The prognosis for patients with follicular or indolent lymphoma has doubled. The survival has doubled over the last number of years. For aggressive lymphoma, the cure rate has gone up from a relatively high cure rate by 10 or 12%. And that's a significant improvement in ability to cure this type of lymphoma. For chronic lymphocytic leukemia, we now have the first treatments over the last few years that have been able to improve the survival of patients with this disease, and also that are able to treat patients with very biologically refractory types of biology. And for Hodgkin's disease, as I mentioned, the cure rate has really rocketed to 85 or 90%, and now the focus is to try to reduce some of the medications, use some targeted drugs. I'm going to show you an example of a targeted drug for Hodgkin's disease that may again reduce some of the long-term complications that have been noted to occur as part of the treatment in a small percentage of patients for Hodgkin's disease. So this just shows what I've been talking about, follicular lymphoma. This is data from Stanford University, where they have a very large sort of database on their results and showing the outcome by decade. And this is the survival that was noted for these patients, and you can see that this curve is continually moving up. And we don't have the last decade, but it's even higher. So this is an example how survival has actually improved for this disease. And this is an example of the aggressive lymphomas, where I said the cure rate has improved by 10 to 12% by the use of this new form of chemotherapy for this disease. And why have we had these improvements in outcome? What are the reasons for it? Well, one is that we have improvements in the diagnosis. I showed you how we have all sorts of different types of lymphomas. We have more precise diagnostic categories, so we know how to treat specific types of lymphoma better. And now we're even getting more precision by using things such as gene expression profiling, and PET has also been an important tool that we've had for diagnosing and staging these lymphomas. We've also had new drugs, and I'm going to actually spend most of my talk talking about new drugs that we have for these various types of lymphomas. And these include very exciting drugs such as monoclonal antibodies, targeted drugs, and immune therapies, an area that I'm particularly interested in. We've also had improvements in supportive care. We have growth factors that bring the neutrophils up quicker so that patients have less likelihood of infections. We have growth factors for red cells. We have better nutritional support, and we have a better understanding of what kind of nutrition patients with lymphoma need. We have psychosocial support, and we have better ways of being able to access veins through various types of devices that we have, which makes the treatment easier for patients. And then another very important part is the multidisciplinary team. It's no one person, it's a whole team, and this is the type of team that has evolved in most major cancer centers across the North America and Europe. It's putting together various types of professionals: nurses, chemo nurses, social workers, pharmacists, psychologists, nutritionists, physicians, and even the physicians. We have medical oncologists, hematologists, we have radiation oncologists, we have surgeons, and even the radiologist who helps us very much with interpretation of the many x-rays that we get on patients with lymphoma. And this multidisciplinary team is key. It's not going out to a local office and being treated by one person. It's the team that you see here at Sunnybrook and at cancer centers across the world that have helped with these improvements in outcome. And of course, we're all familiar with what good teamwork can do. At this time of the year, it's very important to acknowledge the Blue Jays. But this is the actual team. This is a picture that was taken a few years ago of the team here at Sunnybrook, which is composed of the physicians, nurses, pharmacists, social workers, nutrition people, etc. And I'm sure that many of you who've had treatment here have been involved with many of these different people here. So that was a brief introduction on lymphomas. And now I want to sort of focus in on what I think are some of the key advances that have occurred over the last few years and that are ongoing and that are in evolution, because this whole field of science and medicine is a dynamic process. It's never static. It's never stable. There's always new data coming in. There's always new results, and there's always new drugs, and there's always new ways to manage patients that are evolving from clinical trials actually that are taking place across the world. And it's important to recognize that this field is continually changing. So the first thing I want to talk about was some of the new advances in biology and diagnosis. And this is, I think, this may look a little complicated. Certainly a very colorful slide. This is a slide that shows gene expression profiling. And what we're doing is taking RNA from a patient's lymphoma and looking at what genes are expressed in this lymphoma. And actually, this is a composite data. There's actually each one of these columns that you see across here represents a different patient. So we have about 120 patients here that have had this gene expression profiling that was done. These patients all have one disease. They've all had a disease called diffuse large B-cell lymphoma. So we think of this, or we have thought about this for years as being a single disease. But when you look at the gene, the expression of genes, and each row here represents a different gene, and the level of expression is shown here. Red means high expression, green means low expression. First thing you see here is that every lymphoma has every lymphoma, each of which is called a diffuse large B-cell lymphoma, which we've thought of as one lymphoma, has a different expression profile. They're all expressing a different pattern of genes here. But you can clump these into a few different categories, and you have one group of lymphomas, which are all shown along here, where there's relatively high expression of this group of genes on the top here. And this is a type of lymphoma that we call a germinal center B-cell lymphoma. It's been called that because of the type of genes, and it defines the cell of origin that these genes are thought to come from. And then on this side, we have high expression of these genes, and we now call this an activated B-cell. In the middle, we have one where there's really not high expression of any of these genes, and this is called a primary mediastinal or type 3 type of lymphoma. So here we have three major subsets of lymphomas that previously we thought was one lymphoma. And this is really important because it turns out that these lymphomas behave differently than these lymphomas. These have different prognoses. These respond to drugs differently. And I'm going to show you some of that data as we move forward. So this is an example of an advance where we have more precise diagnosis, an understanding of the exact biology of this type of lymphoma that is helping us understand how this lymphoma is going to behave and how it's going to respond. And we can take that one step further. That was what we call gene expression profiling. And I'm sure many of you have heard, if you walk down University Avenue, you see Princess Margaret Hospital, the rival cancer hospital, where they have this big sign that says personalized medicine or home of personalized medicine. Well, every cancer center around the world now is doing personalized medicine, which means gene sequencing. So you can take this one step further. You can actually sequence every single gene in a lymphoma or in any type of cancer or any type of cell. And you can do this in less than a week, and it's actually become quite economical to do so. And when you do that in patients with lymphoma, and actually in patients with diffuse large B-cell lymphoma, again, this category of lymphomas that we used to think of as being one type of lymphoma, you come up with a number of different gene or clusters of genes that are mutated. In the germinal center B cell, you have these genes that are abnormal commonly. I mean, every lymphoma has different genes, but these are the genes that occur in a subset, more than 20% of the patients that are actually abnormal. And for the activated B cell, you have another subset of genes, and for this primary mediastinal B cell, you have another set of genes that are mutated, which are thought to be driving these lymphomas. And this is important because these mutated genes, and I'm going to show you in a few slides how this has been very important in understanding the mechanism that these lymphomas are being driven by, but these give us targets. We know that if there's a mutation, for example, of BCL6, and there's overexpression of BCL6 in a particular category of lymphomas, we can try to develop a drug that will reduce the amount of BCL6, and those drugs are in development. All of these drugs now, all of these genes are the target of various drugs that are in development. And the idea will then be to apply these drugs that target these mutations specifically to lymphomas that have those particular types of mutations. And that's something that is coming. It's not here yet, but we do have examples of, for example, using certain drugs for, let's say, the activated B-cell type of lymphoma. So that's another advance, where we're taking it down to the genetic level. Prognostication, there's also been improvements in our ability to prognosticate for lymphomas. And every patient who has lymphoma wants to have a feeling for an idea of what their prognosis might be. So it's important to have precise ways to be able to prognosticate for patients with lymphoma. But it goes one step further, because if we have a category of lymphomas that has a very good prognosis, such as, let's say, perhaps Hodgkin's disease or types of Hodgkin's disease, we can say, okay, well, maybe we can reduce the treatment to these patients and try to keep that prognosis, where it is, or that outcome where it is. On the other hand, if we have patients who don't respond well to treatments and whose prognosis we can determine at the outset doesn't look that good, maybe we can strengthen their treatment or give them additional drugs or enhance their treatment to try to improve that prognosis. And actually we have trials here at Sunnybrook where we're doing exactly that. So the gene expression profiling I showed you, it's important in helping us understand the biology. It's important in determining what molecules we can target, but it's also important in prognosticating, because if you have a germinal center B cell type of diffuse large cell lymphoma, your survival curve looks like this, or your probability of survival looks like this. Whereas if you have what's called an activated B cell type of lymphoma, it's not quite as good. It's still pretty good. There's still the potential to cure, but it's not quite as good. And that's why there are new drugs being developed for activated B cell types of lymphomas, and we've had studies at Sunnybrook where and at Princess Margaret, there are similar studies where patients are getting some of these new drugs if they have this type of activated B cell type of lymphoma. We do have standard, what we call prognostic indexes, and I'm sure many of you have heard of FLIPI and IPI and MIPI. These are strange names, but they are, FLIPI stands for Follicular Lymphoma International Prognostic Index. These are indexes that have been developed around the world using large databases of patients, just looking at standard clinical parameters. And the standard clinical parameters are shown here. If you have one of these, we call them risk factors. Actually, that's that only one. Then your Flippy score is high. You only have one risk factor. It's called a low risk category, and your outlook is very, very, very positive of the likelihood of survival. On the other hand, if you have 3 or more risk factors of these risk factors, you have a high risk Flippy score, and this is not quite as good as the low risk. And this is a category of patients that we have trials where we're trying to beef up the treatment here to see if we can bring this curve up to that curve. Imaging, PET. Well, I know all of you have heard of PET scans, PET has been a big advance. PET scan is particularly, a PET scan refers to the ability to use positron emission tomography to basically quantitate the uptake of glucose, of fluorodeoxyglucose, FDG. So we heard about how cancer cells require glucose. All cells of our body require glucose. It turns out that cancer cells are hypermetabolic for glucose, and we can see how much of this glucose is being taken up by different cells and different tissues, and generally lymphomas basically take up a lot of this FDG. And this is particularly useful in patients with lymphoma where patients have enlarged lymph nodes. This is a figure which shows the lymph nodes of the body. These are the abnormal lymph nodes. After treatment, the lymph nodes will usually regress, but they won't maybe go down to the normal size that most of the other lymph nodes of the body are. They're a little enlarged. And the question remains, is there active lymphoma in these slightly enlarged lymph nodes, or is that just a reflection of the distorted anatomy and scarring? And one way that we can determine that is by using PET imaging. So this is this patient's lymph node mass with this FDG and positron emission tomography. This is actually the heart and liver and spleen. This is just the normal blood pool. This is the abnormal lymph nodes. And in the situation that I showed you, after treatment where you had that one abnormal lymph node, which is shown here, this does not light up. So this tells us that lymph node was most likely to be scarred and not have active lymphoma in it. So that's a very useful test. What does this all mean in terms of likelihood of relapse? Well, there have been many different studies which have looked at PET scanning in various types of diseases, Hodgkin's, non-Hodgkin's. This is just a summary of some of them. I want to point out just this Hodgkin's lymphoma, which is the biggest study shown in this table here. There are other studies that are done as well. And if your PET scan was negative after treatment, that's a very good negative predictive factor. Only 4 patients out of 216 actually ended up relapsing. So a negative PET scan at the end of treatment for patients with Hodgkin's disease is a very favorable prognostic marker. Whereas on the other hand, if it was positive, you can see a quarter of patients ended up relapsing. So we can calculate what we call positive predictive powers and negative predictive powers. A negative PET scan at the end of treatment for any disease is always a very good negative, is always a good prognostic factor, and the likelihood of relapse is not 0. It's never 0 with this type of scan, but it's very low. And that's very good. The positive predictive power, in other words, if it's positive, does it necessarily mean that there's still lymphoma or Hodgkin's disease there? It's not perfect. In certain situations, it is pretty high. In others, it's only, infers that could be a problem there, and you still have to do a biopsy to determine whether or not that there is lymphoma there, but it basically narrows down the number of patients that we have to do biopsies on. I've had many patients who have had false positive biopsies after a positive PET scan. But this is also something that has contributed to the improvements in outcome that we've seen in patients with lymphoma. We don't have a lot of PET scanners in the province. We can't use PET scanners for every clinical indications. It's primarily used for evaluation of response in this should say in Hodgkin's and non-Hodgkin's lymphoma. And usually for patients who have these lymph nodes that haven't quite gone down to normal. It's also useful in patients with early stage Hodgkin's disease who may be candidates for radiation therapy. We're often wondering, can we omit the radiation? And now we're getting into a standard of care where if we see the PET scan negative after chemotherapy for early stage Hodgkin's disease, we sometimes feel it's comfortable to omit the radiation in certain situations. We can use it for staging for Hodgkin's disease and non-Hodgkin's disease, but really only when we are confronted with early stage presentation and we're wondering who may be a candidate for radiation therapy, and we're wondering if there's disease elsewhere in the body and that would upstage the patient, in which case a PET scan would be approved and allowed. So, but we do use PET scans quite frequently, but we don't have free reign of when we can use them, just because of the availability of PET scanners in the province. And there's an exciting new area. I was at the International Conference on Malignant Lymphoma this spring in Switzerland, which is always a nice place to go to a conference. But this is an area where PET imaging during treatment, particularly for Hodgkin's disease, is a very important new area of investigation. And for example, if you're under treatment for Hodgkin's disease and you get your chemotherapy, and you have an excellent response, so excellent that a PET scan after, let's say, 2 or 3 chemos shows that everything's disappeared, can you reduce the amount of treatment that this patient will get? There are some results now that show that this looks very promising, and that's something that possibly could be done. But there are many studies now that are called risk-adapted management of either early stage or advanced stage Hodgkin's disease, where that question is being addressed using a PET scan after maybe 6 weeks of treatment. And now I'm going to spend most of the time, I hope I have some time left, to talk about new drugs for lymphoma, predominantly non-Hodgkin's, but I will touch upon some drugs for Hodgkin's. And I'm going to focus on cytotoxics, targeted, and immune therapy drugs. But before I start, I wanted to just say a few words about clinical trials. And the treatments that we have now have all been developed through sequential clinical trials that have been conducted around the world. We really don't have any treatments that we use now that haven't been subject to some clinical trials. Clinical trials are very important. There are a number of different types of clinical trials. We call them phase 1, phase 2, or phase 3. Phase 1 trials are very early trials where there's a new drug that has come out of some preclinical studies from a laboratory somewhere, and where it's looking promising, but we have to determine what's the safety profile of this drug and what's the proper dose of this drug. So this is usually a phase 1 type of trial. It's usually a small trial. There's usually dose escalation, and it's usually a smaller trial. Phase 2 trials are trials where phase 1 study has been done, the safety profile has been determined to be acceptable, the dose is known, and now investigators are trying to figure out, well, does this have some activity? And very surrogate type of endpoints are used. Will the lymphoma respond? What's the duration of response? This is usually a slightly larger trial, and it takes a little longer to do. The definitive trials are phase 3 trials. These are usually randomized trials. Trials in this situation are often used for regulatory approval of drugs. These require important endpoints, important from the point of view of patient. Will a patient live longer if they get this drug as part of their treatment? And sometimes, or will they stay in remission longer? These randomized trials usually require a lot of patients, minimum of about 500 patients usually, and take quite a long period of time. So you can see a new drug that comes out of a university somewhere can take 10 years before it could possibly be approved as a drug that can be used in the clinic. Trials can be single-center or multi-center. They can be sponsored by an investigator. We have a number of investigator-sponsored trials here at Sunnybrook and Princess Margaret. There are investigator-sponsored trials, but they could be sponsored by a pharmaceutical company that has an important drug that they're trying to develop, or cooperative groups such as the National Cancer Institute of Canada. We do a number of cooperative group trials. Every clinical trial must be approved by Health Canada before it can go forward. Must be approved by a local IRB. These are reviewers, including the public, that reviews the trials and says, this makes sense, this is ethical, this is safe, this is going to be done properly, and there will be a useful answer that comes based upon how this trial was designed. And the trials have to be performed in what we call good clinical practice standards, which are standards of data collection, and et cetera, and confidentiality. So trials are important. I encourage patients that I look after to participate in trials whenever there is an appropriate trial for them. We know of the trials that are being done locally. We can make recommendations for those trials. It's also possible to find trials that are being done elsewhere. Every center will have some larger trials that are being done in multiple different centers. And so you can get that trial in Alberta or Ontario. But there are some trials for very special indications and very special situations that are only done at one center. And you can find out about those centers through this very important website called clinicaltrials.gov. I use it myself quite frequently. I recommend the patients use it. You put in your disease or the disease that you're interested in, the situation that you're interested in. You can get a listing of every trial, because every trial that's being done has to be listed in this website, every trial that's being done in North America and Europe. So this is a very valuable resource. And it gives you contact information as well, who you can contact to get into that trial. But of course, ask your hematologist or oncologist. They'll be able to help you with this. So now let's talk a little bit about new drugs. I'm going to start off with a new old drug. And this is a category of drugs which we're actually decreasing in terms of using, or hope we're going to be decreasing in terms of using, a cytotoxic drug. Cytotoxic drugs refer to drugs that we have accumulated over the years that are non-specific for the cancer, basically drugs that are able to kill dividing cells, but unfortunately are not specific for the cancer cell. They also harm normal cells. That's why we have many of the toxicities from chemotherapy. I'm going to spend most of the time talking about targeted drugs and immune drugs, which are more specific for the cancer. That's the exciting area, and that's where the field is headed, to be using those types of drugs. But this is a very important drug. This drug came out of East Germany. It was found to be very useful by scientists and clinicians there in East Germany. It only became available when politics allowed East Germany to be part of the rest of the world. There were a number of studies that were done in North America, and it was approved in 2008 in the US, and now it's been approved in Canada. And this is a cytotoxic drug. It has many of the side effects that we know are common with some of the chemotherapies that we use, but it is a very effective drug. This is a study for patients with indolent lymphoma that were randomized to receive either a standard that has been used throughout the world, one of the standard treatments, we use a slightly different standard, or this bendamustine drug. That's what we're talking about here, bendamustine. And you can see that this survival curve, so this is the probability of survival with time, and this is actually progression-free survival. It's not overall survival, but the point is this is a dramatically increased progression-free survival. Patients actually had a median progression-free survival, so that's a period of time without relapse of 70 months as opposed to 31 months by using this drug instead of our standard drug for indolent low-grade lymphoma. In this study, there were a number of different types of lymphoma that were used, and actually you can see the survival curve is better for all the different subtypes, including Waldenstrom's, marginal zone, mantle cell, and follicular lymphoma, although there weren't as many patients in some of these subsets. And for example, in marginal zone lymphoma, the survival curves are different, but the point is that it's not significant just because there were fewer patients that had marginal zone lymphoma in this trial. But this is the other important point about this drug is that it's not as toxic. The side effects aren't as great as with the standard therapy that we had been using. This just shows the neutropenia. It was actually cut in half with bendamustine and Rituxan as opposed to CHOP and Rituxan. So that's a big improvement. And in addition, it didn't cause hair loss. There was less numbness side effect or paresthesias, and it didn't cause as much soreness of the throat. And there was less infection. So it is a very good drug. It's now our standard of care drug for patients with indolent lymphomas in combination with Rituximab. So that's an advance in the field of cytotoxic drugs. Now I'm going to spend the rest of the time talking about targeted drugs and immune therapy. And this has been basically a very important area that to some extent has been unique to lymphomas, although there are targeted therapies now in a number of other cancers, breast cancer, colon cancer, but they've basically followed the lead set in the area of in the field of lymphoma. And lymphomas are B cells, and they're malignancies, or they're transformed B cells. And B cells express a number of unique proteins on their surface and also inside the cell that make them a B cell. And these proteins, actually all of these proteins here, are not expressed on any other cell in the body. They're not even expressed on T cells. They're expressed on B cells, and they're also expressed on the cancers that arise from B cells, or B lymphomas. So these are very specific targets that you could imagine that if you developed a target to CD20, for example, that would potentially have activity against only B cells and B lymphomas. And that's in fact exactly what Rituxan is. Many of you receive Rituxan. Rituxan's been around for over a decade now, but it is one of the first examples of a targeted monoclonal antibody that has really has fundamentally changed this field of lymphoma. Every chemotherapy that we use now is enhanced with Rituxan. We use it for maintenance. This has been a super drug, if you can ever call anything a super drug. Antibodies consists of proteins. This is the part that binds to the actual target. This is what binds to CD20. And this is the effector region of the antibody. So this is the region that helps with the killing of the target. And there's a number of different mechanisms where this antibody results in killing. And the antibody will bind through this region to your B lymphoma through CD20. But this region then either binds to complement or to immune effector cells, which can either be polymorphonuclear cells or natural killer cells. And it's these cells that actually are responsible for killing the lymphoma cell. And that's one mechanism of cell kill. I mentioned it can also bind to complement, and Rituxan can also cause some direct predisposition to apoptosis, or to killing the cell. So there's a number of different mechanisms whereby Rituxan can actually kill lymphoma cells. But studies over the years, sequential clinical trials that actually we've participated in here in Princess Margaret and other centers across Canada, have shown that the addition of Rituxan to standard chemotherapy has improved the results, have improved the duration of the response and survival in all of these studies. So this is one of the first studies that was done. This is taking what was then the standard of treatment. I told you now it's bendamustine, but at that point when this study was done, it was cyclophosphamide, vincristine, and prednisone. And patients were randomized to receive either that or that and Rituxan. And if you look at the duration of response, if you just received that chemotherapy, your response was about 1.5 years before we felt your lymphoma would come back. When we added Rituxan to that combination, it now became 32 months. So patients basically had responses that on average lasted twice as long. And then the next idea, well, if it works so well when you combine it with chemotherapy, what if you give it after chemotherapy? Because we know that most of these patients will relapse. What happens if you give it as maintenance therapy? And that was done in a number of studies. This is one example of a study that was done. And the duration of response now lasted 5 years. So you go from a situation where you had 1.5 year remission to a 5-year remission. And this is ongoing now, going to be even longer when we use bendamustine and Rituxan as our frontline therapy as opposed to CVP and Rituxan. So I think you'd all recognize that this has been a huge advance in the management of patients with this type of lymphoma. This is another study that was done with aggressive or diffuse large B-cell lymphomas. I told you now we have germinal center B cells and activated B cells, types of diffuse large cell. This was just done with diffuse large B-cell lymphomas. At that time, we treated patients with just CHOP or a CHOP-like chemotherapy. And this study randomized patients to receive either this chemotherapy alone or chemotherapy and radiation. And the results of this trial, again, were a success. This is survival. It's a survival curve, and this shows a significant improvement in the likelihood of survival in patients who receive Rituxan as part of their chemotherapy for diffuse large B-cell lymphoma. In this, the other important point from this trial was that when you looked at the side effects from patients who received Rituxan chemotherapy versus just chemotherapy alone, the percentage of side effects was not any different. So Rituxan, being a targeted agent and having the features that I told you, that it just targets B cells and B lymphoma cells, didn't add to the toxicity. And that's a really important point. We want to start using drugs that are effective but don't increase the side effects. And that's what we have to offer. And I'm going to show you one more example of the importance of Rituxan. This is in a disease called chronic lymphocytic leukemia. And this is a trial where our standard treatment for this, for fit patients, and we have different ways of, we have what's called a Sears index, which is a complicated comorbidity index, which we use. And patients who have a favorable Sears index are candidates for this type of therapy called fludarabine and Rituxan. And this is a study where patients were randomized with CLL who were fit to receive either fludarabine and cyclophosphamide or Rituxan, fludarabine and cyclophosphamide. And this trial was the first example in the whole literature for CLL where there was an improvement in survival in patients who got this particular chemotherapy. So this was a big breakthrough, and now Rituxan is being tried with a number of different combination drugs that is being used for CLL. Now the problem with this particular combination treatment is shown here. This is probably the strongest treatment we have for chronic lymphocytic leukemia, but it also has a lot of side effects. So fortunately, the side effects were much the same, although there was a slight increase in neutropenia and infection that was seen in patients who did get Rituxan and fludarabine and cyclophosphamide versus fludarabine and cyclophosphamide alone. But 3/4 of patients with this chemotherapy had serious adverse events. So this is not a treatment for everybody, but if you're going to use it, you're going to use it with Rituximab. Now, the field has moved on, and Rituximab was the first monoclonal antibody against CD20. There's now 4 or 5 monoclonal antibodies that recognize CD20 and some of those other molecules I showed you on the surface, CD22, CD19. And this is the most advanced version of some of these new monoclonal antibodies. This is called GA101. Actually, that was its first name, then it was called obinutuzumab, and now it's called Gazyva. So its name has changed, but it's the same molecule, and I don't know how they come up with these names, but they do make it difficult for us to spell them anyway. This antibody recognizes an overlapping epitope of CD20. So it's recognizing almost the same part of the protein as Rituximab, same part of the CD20 molecule as Rituxan. But it's a type 2 antibody. So the bottom part of this antibody, the FC part, has been engineered to result in increased ability to induce antibody-dependent cellular cytotoxicity with those natural killer cells and neutrophils that I told you about, and also to directly produce a signal that kills the lymphoma cell. And this just shows the mechanism of activities, enhanced ADC, increased cell death, because of the engineering that went on in the FC part of that monoclonal antibody. And it turns out that through the initial studies, the phase 1 and phase 2 studies, this showed particularly promising activity in chronic lymphocytic leukemia. And this study was performed, again, as a head-to-head comparison of chlorambucil and GA101. I'm going to use GA101 because it's easier than obinutuzumab. Of chlorambucil and GA101 versus chlorambucil and Rituxan, the previous standard of care, in newly diagnosed patients who were not fit enough to receive that FCR combination that I showed you initially. And this just shows the schema of the trial. It's basically a randomized trial to receive one of the 2 antibodies with chlorambucil, which is what we use for patients who aren't as fit. And this shows the results of this trial with respect to progression-free survival. And this shows that by using this new monoclonal antibody compared to Rituxan, you actually have a significant increase in the duration of responses in patients who receive this antibody. So this is an advance forward, and this has resulted in actually approval in the United States for this drug and by Health Canada, although we don't yet have funding for it. This study is still underway in terms of the follow-up of these patients, and so far there hasn't been a big increase in the survival, but follow-up will continue. The toxicity profile is much the same, although it does turn out that it's a little bit more difficult to infuse it, and there are more infusion-related toxicities. With this, it doesn't seem to be a big problem. I want to talk about one other type of monoclonal antibody. I see I only have 5 minutes left. And this is an antibody which is taking this all one step further. So this is recognizing CD30, not CD20. CD30 is expressed on T cells, and it's expressed on Hodgkin's disease cells. But instead of relying on the patient's own immune system to kill the cells, a toxin is attached to this antibody, and this is called monomethylauristatin. The antibody is called Rituximab, and it binds to the cell that expresses CD30. This antibody gets internalized, the toxin gets released, and it kills the cell. And this is a study from patients with Hodgkin's disease. Almost every refractory Hodgkin's disease, recurrent Hodgkin's disease, almost every patient who got this monoclonal antibody had a response, some level of response. So this drug is now approved for patients with recurrent Hodgkin's disease and recurrent T-cell lymphomas. We've, here at our center at Sunnybrook, have done studies with this as first-line therapy for Hodgkin's disease, where we've left out one of the drugs that we think has side effects in the ABVD combination. And it's a randomized trial to ABVD versus ABVD minus one of the drugs with this new drug, and we've also had a trial in T-cell lymphoma. There's one other type of immune therapy I want to talk about. This is an area that I've done quite a bit of research in myself. It's a very important new form of therapy. And this is a therapy where we're relying on the T cell itself to try to kill cancer cells. Now, T cells are meant to recognize pathogen, recognize bacteria, recognize viruses, and recognize cancers and kill them. But cancers are smart. Cancers put up defenses, and they prevent the T cells from becoming fully activated. And some of the molecules that actually mediate this inhibition of T cells have been identified, and they're shown here, these inhibitory receptors. And these two in particular are important because it's been possible to make antibodies that can block these receptors and result in stimulation of the T cells, an ability to kill the cancer. And these drugs are becoming very important in oncology in general. These have now been approved in melanoma and lung cancer. There's been a study that was reported at this meeting I told you in beautiful Switzerland, where the response rate was 87% in patients with Hodgkin's disease, who again were refractory, and also in diffuse large B-cell lymphoma and follicular lymphoma that had failed other treatments. So this is a drug that we're very excited about. Will be combined, as I've shown you some of these other drugs are, with standard of care treatments, and we think it's very promising. And the last bit of data I'm going to show you, I know I have about 1 minute left, and I think is this slide here, and I'm not going to go into this in detail, but this is meant to just show you that with all of this sequencing that's being done in lymphomas, these stars represent common mutations that are found in a number of different lymphomas. So, for example, this CARD CD79 mutation is found in 15 or 25% of diffuse large B-cell lymphomas. MYD88, it turns out, is found in 95% of patients with Waldenstrom's. But these are mutations, and these mutations result in hyperactivity of certain pathways that drive these lymphomas, that are responsible for these lymphomas. And it's now the strategy is to develop drugs that will overcome the hyperactivity of these molecules. And these actually have been developed. There's a number of these different drugs. These squares show the drugs that are actually in development working on these different mutations. This table here shows the 4 most important drugs that are most advanced now in clinical development. Ibrutinib tackles this MYD88 or BTK hyperactivity. It's been approved in a number of indications. Revlimid is very important. Velcade and idelalisib, which is another very important drug, which attacks one of those molecules that is mutated. It's being approved. We're doing trials here. I've had patients on some of these drugs on certain indications. They're not yet funded for the most part. We have to get special approval and different ways to fund these. But these are going to be very important. They're going to be part, as I've shown you, of combinations that we're going to be using in the future. These aren't free of toxicities, but they have different toxicities and less severe toxicities in general. This is my second last slide. And the other important point about this is that these drugs have the ability to have activity in biology. So this is patients with CLL who have this mutation of P53 or 17P. These patients, you can see the survival curve is not very good. It's not nearly as good as many of the other types of CLL. And actually, these patients hardly respond to most of the standard drugs we have. Well, drugs like ibrutinib and idelalisib, actually, studies have already shown that these patients respond as well to these drugs as these patients. So it's overcoming some intrinsic problems with the biology with these new drugs, and that's very exciting. So this is the last slide. We're here finally. There have been many clinical advances in the treatment of non-Hodgkin's lymphoma. Rituximab has been a key driver, and it's been systematically evaluated through ongoing clinical trials. I think I spent a little time talking about prognostic indicators. It's really important because it helps us figure out which patients we should have in trials, and it also gives patients information, and we're getting better prognostic indicators, whether it be molecular or PET scanning. We have this, I showed you in the last few slides, this incredible understanding, increasing understanding by the ability to sequence every gene in these cells of what genes are actually mutated, what they're doing to lymphoma, and now we have targets for specific drugs that can overcome the fundamental abnormalities in these cells. So the point is that with all of this, everything is looking very promising for the future for patients with lymphoma.